Good morning or good afternoon, whatever time of the day it is. I want to thank Michael Petrosian for giving me the opportunity to discuss neuroblastoma with you today. Well, we all know that pediatric cancer since the 1950s has made incredible progress. As you can see, before the advent of chemotherapy, the survival rate of pediatric tumors was very low. And then when Dr. Faber in Boston started treating with cancer therapy, the survival improved progressively. However, if you now look since the 1990s, or certainly since the 2000s, the significant changes in tumors like neuroblastoma has been very minimal with regard to improving survival. Many of the other solid tumors, like Wilms tumor, of course, has a very good survival. It's above 90%, so the change wouldn't be expected. However, neuroblastoma, where overall survival for all comers is about 50% for the high-risk disease, we would hope to make significant improvement, but we've sort of hit a plateau. Well, what is neuroblastoma? We know it's an embryonal tumor of the neural crest, develops in the sympathetic nervous system along the sympathetic chain. Most of them occur in the adrenal region, over 50%, and the other 24% is paraspinal, making it about 75% along the spine or adrenal region. There's a large proportion of about 20% in the mediastinum. It is the most common extracranial solid tumor. And even if you had to define intracranial solid tumors by their phenotype or their type, neuroblastoma would be probably the most common solid tumor in childhood. In America itself, there are about 550 new cases a year. That's about 1 in 7,000 live births. And it's really a spectrum of disease, from ganglioneuroma to ganglioneuroblastoma to neuroblastoma. Most commonly, the tumor is seen as an adrenal mass, and you can see in this picture over here with a CT scan this large mass in the adrenal region compressing the inferior vena cava. Its clinical presentation is very dependent on its symptoms, which do vary according to the location of the disease. As I said, an abdominal mass is present in about 50% or more than 50% of cases and can be identified as such. Anemia, failure to thrive, and weight loss. In the posterior mediastinum, it can cause respiratory distress. In the superior mediastinum, Horner syndrome, meiosis, anhidrosis, and ptosis of the eyelid. Orbital mets can induce proptosis or panda eyes, where the eyes stick out. Bone mets can cause bone pain or limb pain. Hypertension when catecholamines are secreted. And when it invades into the spinal foramina, it can cause paraplegia or cauda equina. The opsoclonus nystagmus syndrome is very unusual, and it really speaks to the immunogenesis of this disease, in that either an antibody complex or T cells are attacking normal neural complexes. These patients can get hypokalemia, watery diarrhea, due to VIP secreting tumors, which is rare. And then the neonatal disease can present as hepatomegaly or with subcutaneous tumor nodules. So these are some of the clinical features. I spoke about the raccoon eyes and the proptosis. And then these mulberry syndrome, where you get these lesions all over the body, specifically in the newborn children. What's the diagnostic workup? Radiologically, you can get a plain film and you could see stippled calcifications in the adrenal mass. A CT scan will show depression of the kidney and displacement downwards, but it doesn't have that claw sign that really encircles the kidney that is seen with Wilms tumor. MRI is done when there's spinal extension and perhaps weakness in the legs, cord equina. A bone scan is useful for technetium-99 that lights up lesions in the bone. And then an MIBG scan is very important for both primary disease and metastatic disease, as when it lights up, it gives you a very good idea of the activity of the tumor and the uptake of the MIBG. These tumors obviously secrete epinephrine, norepinephrine, and also the breakdown products that can be detected in the urine. So we frequently check urine for HVA, homovanillic acid, and VMA, vanillyl-mandylic acid, which are both breakdown products of DOPA or norepinephrine. This is just some plain films showing the calcification that one can see in the adrenal region on the left here. This is a very large mass, obviously encircling the aorta, compressing the inferior vena cava, often affecting the renal vessels on both sides. Paraspinal masses, as you can see here, can insinuate themselves into the spinal foramina at each level, causing significant neurologic impairment. And in the thorax, they can often be identified and seen in the paraspinal region. The MIBG scan shows uptake in various sites, not just in the primary site in the left adrenal, but also in bone metastases. The pathology of this tumor is always small blue cells. They say they form rosettes. I'm not exactly sure what they mean by that, but they are a circular clumping of small blue cells. The Shimada classification is a classification we use to identify the pathology, both in stroma-rich and stroma-poor, and has a significance for the prognosis of the disease. Neuroblast differentiation is important if it's differentiated or undifferentiated. The mitosis karyorrhexis index for 5,000 cells is counted to look at the proliferation rate of the disease, and then we know that the age of the patient is very critical in not only the prognosis of the disease, but also in its dictation of how the pathology turns out. So the classification is neuroblastoma, undifferentiated, poorly differentiated, differentiating. Ganglioneuroblastoma is either intermixed or nodular, and ganglioneuroma, which is maturing or mature. So that is the spectrum of the disease from completely benign disease to highly malignant. This is what a neuroblastoma may look like. This has obviously got some cystic degeneration in the center. These are the undifferentiated small blue cells. I don't really see rosettes, but just intense packing of undifferentiated blue cells, of neuroblasts. This is poorly differentiated, a little more stroma-rich. You're starting to see some larger cells, not just the small blue cells, and then the differentiating, where you're starting to see almost these ganglion-type cells being formed. So neuroblastoma is also very dependent on the histology and the age. In other words, if it's undifferentiated, all patients have high-risk disease, which is unfavorable histology. When it's differentiated, the age is dependent. Even in a patient who's greater than 5 years old who has differentiated neuroblastoma pathology or poorly differentiated, the impact is very different. The intermixed ganglioneuroblastoma has both differentiated and undifferentiated, and the nodular phenotype, which can be very malignant, forms large nodules in the tumor itself. This is an example of the nodular phenotype that has a large mass with small blue cells that is encircled by differentiated tissue. So the maturing ganglioneuroma These are more benign, and you can see very differentiated ganglioneuroma tissue. And then the mature or differentiated, completely mature, is completely benign. And one often doesn't know what to do with these. Do you actually take them out, or do you just leave them in place? And I think that's the parents and the dealer's choice. All right, so for favorable neuroblastoma, there's stroma-rich and stroma-poor, depending on the age of the patient. And for unfavorable, these are usually nodular stroma-rich, and the rest are usually stroma-poor, even if they're younger children. What's very important about neuroblastoma is its molecular pathology. MICN amplification is really the most famous, and it really is a marker of poor outcome and poor prognosis. MICN is found on the short arm of chromosome 2. It is present in about 25% of primary neuroblastomas. In low-stage disease, it is only present in about 5%, whereas in advanced disease, it's usually present in about 40%. It is, as I said, a very important prognostic indicator. The original staging system by Evans, unfortunately Audrey Evans, who was 97, passed away, I think it was last weekend, but she really defined the tumor as a staging classification system that really had importance for outcome of patients. We've moved on from that staging system to the International Neuroblastoma Risk Group staging system, where we have L1, which is local disease, L2, local regional tumor, but has the presence of more than one image-defined risk factor, which I will show you. Stage M is metastatic disease, and stage MS is metastatic disease in younger children under 18 months old, but it is confined to the skin, liver, and bone marrow, and not in the bone itself, only in the bone marrow. So what I was referring to, this is the classification system, L1, L2, M and MS disease, dependent on histology, the age of the patient, but very importantly, the MICN amplification. And you can see whenever MICN is amplified, it becomes high-risk disease, even if it's L1 stage, and even when the children are less than 18 months of age. And MIC amplification, very high, ultra high or high risk of disease, and that gives you a great idea about what the best treatment is for these kids, and also the different forms of treatment that are applied depending on the risk classification. So, as I alluded to in the new risk staging system, image-defined risk factors are dependent on whether the tumor is encircling major structures, if it's encircling the portal vessels. But when the tumor is local and clearly identified, it's a low risk, and that's an L1, whereas this image-defined risk factor would make it this one an L2. Really, the concept of this international staging system is so that you can sort of group tumors in an appropriate fashion and then understand the outcomes for all patients. Well, what are the principles of standard initial therapy? Surgery, of course, is to establish the diagnosis, although we now often do it with percutaneous biopsy. If you do percutaneous needle biopsies, you need a whole bunch of them, probably about 16, because it's important in these patients to do the molecular pathology, which is the NMIC amplification, and also now there's been other mutations that have been identified, like ALK. We wish the tumors, if the tumor is excisable or resectable, of course you should probably take it out initially, but most of these patients are not, and a delayed primary or secondary look surgery is necessary to really remove any residual tumor. I do want to highlight that that's the surgical aspect, and we will get into the chemotherapy, radiation, and immunotherapy aspect, because for these tumors, especially the high-risk tumors, we really throw everything at them, including the kitchen sink, so to speak. So the surgical technique, well, it's a large abdominal incision. You peel any tumor off vessels if it's amenable to resection. You do lymph node sampling, not like in Wilms tumor, but certainly if there are large lymph nodes around, and liver biopsy if there's any concern for abdominal liver metastases. For the thorax, we do a posterior lateral thoracotomy, and if there's neurologic symptoms, one often does or gets our neurosurgical colleagues to do a post-laminectomy first, decompress the tumor, save the injury to the spine and neurologic endangerment, and then we start either chemo and then resect the remainder of the mass or resect the remainder of the mass at the same time. Well, what are the principles of surgical resection? And I jokingly say, are there really any? Well, for low-risk disease, if it's localized tumor, you do a complete resection. But if it is really low-risk disease, it's differential ganglion neuroma, you can obviously observe these patients as well, even some of the more intermediate risk patients. However, for intermediate risk, our goal is to resect as much tumor as possible, and it's usually over 50% of the tumor. And for high-risk tumor, there are groups that say you need to be aggressive and completely resect everything, and there are others that say a limited approach is adequate because it's not really up to the surgical resection for cure. It's really up to the pathology of the disease and its response to chemotherapy or other therapy. The surgical technique is an as I described previously. This is just a repeat of the same slide, but I just wanted to show you some of the techniques that we do. So here is the tumor in the pelvis, organ of Zucker-Candle supposedly, and we resect it off the vessels. It does come off, it's not that simple, and if you need to get to the adventitia of the artery, that's appropriate, but you can define these things and remove the tumor. This is a tumor in the right adrenal region, encircling the inferior vena cava, and the inferior vena cava is often frequently separated from these tumors as well. The Horner syndrome, the ptosis, meiosis, and hydrosis. On the right side here, you can see the tumor and the ptosis on the eyelid. And these tumors, again, are densely and closely interrelated, but they can be removed. I use a open book type approach, which is an incision in the neck, part of the medius, part of the sternum, and across to the right side, and that allows opening of the chest to get to that area. This is an example of a tumor. Now, the process that we use when we do a large tumor is mobilize the colon completely over, mobilize the spleen and the kidney to some extent if necessary, and that gets incredible access to the tumor so that it can be completely removed. Some of these tumors are cystic. Some are cystic after chemotherapy and get cystic degeneration, but others just have a cystic component. And so even if you're removing a tumor like this that hasn't seen chemo, and you say, oh, we can remove this, and I doubt it's a neuroblastoma, they can still be neuroblastomas. And then, of course, the young babies, the MS type staging system, where they have metastatic disease all over, specifically in the liver, and then also a mass in the adrenal. And these children often are biopsied on a superficial lesion and then observed, unless, of course, they are short of breath and it's compressing the other systems. The complications of surgery are significant. One obviously wants to keep these as low as possible. Incidence has been described anywhere between 5 and 25%. Damage to the kidney, nephrectomies have been done. Not necessary, shouldn't be so aggressive. It doesn't make that much difference to the outcome. Of course, remove as much tumor as possible. That's my philosophy, but it's not absolutely necessary at the risk of damaging a kidney, for example. When these kids get chemotherapy, they get nephrotoxicity, and they need all the nephrons they can possibly spare for managing the chemotherapy. You can get small bowel obstructions with intersusception or adhesion. Intersusception with large retroperitoneal dissections is not that uncommon. And then, of course, the infections and lymphatic leaks that one sees in pelvic nerve injuries. Horner syndrome must always be described when going into resection of a upper chest paraspinal mass. This is quite common, and often the Horner syndrome is actually the first thing that's detected even before the surgery is performed. This is an interception seen as a surgical complication after a large retroperitoneal dissection. The chemotherapy can be standard and high dose with autologous hematopoietic stem cells. Radiation treatment. Neuroblastoma is a radiosensitive tumor, and it's an adjunct certainly for local control or for palliation of symptoms if there's compression of the cord, etc. So for non-high-risk disease, this is lower-risk disease, for stage 1, perinatal patients can often be observed. If they are symptomatic because of compression, then certainly a resection can be done, but is usually not done. The abdomen is open, you can put a silo in and start chemotherapy early. For MS disease, which is also favorable histology, similarly, asymptomatic is just observed, and if they're symptomatic, you can start chemo or radiation therapy. For MS disease with unfavorable histology, treat up front with chemo and radiation, and then resect later as needed. For L2 disease, and this is the more extensive local disease that involves the vessels and structures of the abdomen, these patients are often biopsied, phenotypes, in other words, do they have molecular and MYC amplification, and these patients undergo chemotherapy 2 to 8 cycles and then undergo resection of residual disease, and the goal here is at least partial resection, more than 50% of tumor size. Now this is non-high-risk disease, sort of considered as intermediate disease. When we discuss high-risk disease, however, the plan is induction chemo with 5 to 6 cycles, then surgical resection of the primary tumor, followed by consolidation therapy with tandem transplants, myeloablative chemotherapy and autologous hematopoietic stem cell transplant, so it's the patient's own stem cells, and then radiation therapy. And then finally, what's been added now is biologic therapy with retinoic acid and immunotherapy with ganglioside GD2. So this is really the treatment strategy: 2 cycles, stem cell harvest, then 3 cycles. At the 5th cycle, you go to surgery, a 6th cycle, and then high-dose chemo with bone marrow transplant, radiation, and then biologics and immunologic therapy. And the outcomes: event-free survival by risk stratification, low risk, intermediate risk, and high risk. And you can see a clear demarcation. In fact, the intermediate risk with a 50% resection still has about an over 90% survival rate. But the high risk, which is the problem with neuroblastoma and the challenge that we face as oncologists and surgical oncologists, is trying to improve the outcome of these patients. Now, the interim analysis of the GM-CSF plus IL-2 plus anti-ganglioside GD2 therapy really showed a significant benefit with a 2-year overall survival of 86% versus 75%, and a 2-year event-free survival of 66% versus 46%. This is also shown in this slide over here at 2 years, 66% versus 46%. But you can see even despite this, after 2 years, the curve unfortunately does go down, and the overall survival in these patients is still about 50% in these high-risk patients. So if I could give you my bottom line on neuroblastoma, and thank you again for giving me the opportunity to present, but it is a tumor of neural crest origin. It somehow forms in babies. If you take fetuses, it's more common than you think, but a lot of the time it undergoes its own destruction, whether it be apoptosis or some immune-mediated event, no one really knows. It is the most common extracranial solid tumor. It has a varied clinical presentation, dependent on what it secretes and dependent on its site, whether it's compressing the spine, whether it's extensive in the neck, causing a horniness, or whether it's an abdominal mass in the abdomen. The workup is obviously dependent on radiology, from simple x-rays with stippled calcification to CT scans, MRIs, and MIBG scans. The analysis of these tumors, in assessing it, is a risk-based analysis, so the patients really, by their pathology, by their age, by their NMIC amplification, will really give you an idea of the prognostic outcome, which also dictates the type of therapy that's necessary. So, although most of these present with advanced disease, and those ones with advanced disease have a very poor prognosis, from a surgical perspective, one must remember that if it can be completely excised, remove it completely. If it cannot be completely excised, treat with chemo, and then resect more than 50% or as much as possible, and the outcomes are pretty good. It's those high-risk disease where it's really uncertain whether the gross complete resection versus partial resection makes any difference. I think the neuroblastoma is a good example of an advancement in immunotherapy, and its simple ganglioside GD2 antibody has advanced the outcome of these highly aggressive, high-risk patients. I think there's opportunity for further immunotherapies in the future, and I think that's where our research and our work needs to go to really improve the outcome of these patients. Again, thank you for your time, and I hope you found this short presentation